So let's talk some words on vestibular schwannoma, which is a benign tumor that arises on the vestibular part of the vestibulocochlear nerve. Therefore, the name vestibular and the name schwannoma is because it arises from Schwann cells. Now, another name is acoustic neuroma, but it is a less successful name. The reason is that the vestibular schwannoma doesn't arise from the acoustic part of the vestibulocochlear nerve. It arises from the vestibular part of the vestibulocochlear nerve. And it's not a neuroma. It doesn't arise from the neural cells. It arises from the Schwann cells. Therefore, the name vestibular schwannoma is much better than the name acoustic neuroma. Anyway, this is a tumor that arises usually in the cerebropontine angle um, and arises from the vestibulocochlear nerve in the vestibular part. This is a benign tumor, and after it arises in the vestibular nerve, it starts to compress the cochlear nerve. Therefore, it causes hearing loss. Now, it is usually unilateral. If it is bilateral, you need to think about neurofibromatosis type 2. But it's usually unilateral. Therefore, there is a compression of the cochlear nerve unilaterally. Therefore, we get to unilateral hearing loss. Another common manifestation is tinnitus, unilateral asymmetrical tinnitus. Again, aside from the case of neurofibromatosis type 2, where where vestibular schwannomas can arise bilaterally. But usually the sporadic type, which is the more common generally or totally, we're talking about unilateral tinnitus, unilateral hearing loss with asymmetry in geometry. Now, vertigo is much less common symptoms. Imbalance may occur, but vertigo and imbalance are less common. And this is a little bit counterintuitive because vestibular schwannoma arises from the vestibular nerve, so you would expect that vestibular symptoms will dominate. But this is not true because this tumor is slow growing. Therefore, it doesn't cause a lot of vestibular symptoms because the brain can compensate for the very slow change in the vestibular nerve signals. Therefore, vertigo and imbalance are not common manifestations of vestibular schwannoma. Hearing loss, tinnitus are much more common. Now, in order to diagnose it, we are using MRI with gadolinium, namely contrast, because this nerve in the cerebropontine angle usually enhances with contrast. Now maybe I'll be able to show you. Here you can see this is the internal acoustic canal where the vestibular nerve arises, where the vestibular nerve passes. Let's get to the image. This is the internal acoustic canal, and thereafter you see the cerebropontine angle between the cerebellum and the pons. There the vestibulocochlear nerve arises as the eighth cranial nerve, and you can see this enhancement, sometimes heterogeneous enhancement, of this like cup from the internal acoustic canal. This is the vestibular schwannoma. And this is the gold standard for diagnosis after you suspect it, for example, in asymmetry or geometry, more than 20 decibels sensory neural hearing loss between ears in one frequency. You need to suspect it, or there is unilateral hearing loss, or something else causes you suspicious. You do an MRI with gadolinium, you look on T1 with contrast, and you can see this enhancing lesion coming from the internal acoustic canal and sometimes get into the cerebropontine angle. It doesn't have to get there. Here you can see there is nothing but no schwannoma, but here this is the vestibular schwannoma. You can see that without contrast you won't really see it too much because it's a little bit hypointense, but you can see it touches the brainstem, and it starts usually in the intercraniocular space. This is because in the intercraniocular space there is this transition between the central nervous system and the peripheral nervous system in terms of cupping the nerves. And there, in this transition zone, there are abundant of Schwann cells. Therefore, the vestibular schwannoma can arise there. Now it can protrude to the cerebral point line angle, as you can see here, touch the brainstem and even compress it. And there is a grading for it called the Coos classification. There are grade 1, 2, 3, 4. 1 only intercanalicular, 2 going to the cerebral point line angle, 3 touches the cerebellum, and 4 compresses the cerebellum, as we can just see here. It's important for classification for planning of treatment. But let's get back. So we saw the MRI with contrast as a gold standard for the diagnosis, and audiometry help us understand if we need an MRI, because if there is sensory neural hearing loss that is asymmetric without any other cause, for example, not acoustic trauma or I don't know, something else. Now, in terms of treatment, it depends on the size of the tumor, how fast it grows. So you need sometimes serial MRIs. And what are the symptoms of the patient, how worse he gets with time, and the compression on the brainstem. Now, if there is compression on the brainstem, for example, you will go to surgery. But if the tumor is very small, only intercanalicular, no symptoms or no very prominent symptoms, only maybe a little bit of hearing loss, and the patient is old, you may observe the tumors. Some of them grow, some of them not, some of them even regress. Most of them grow with time, but you need in observation to follow the patients. And let's say if the tumor is under 3 centimeters, yeah, I'm not wrong, under 3 centimeters, and you want to treat the patient, but you want to preserve, for example, hearing, or you just want to delay the growth rate of the tumor and you don't really need the surgery, you may go with stereotactic radiosurgery, but it's for more smaller tumors, less than 3 centimeters. Microsurgery, there are some approaches. There is the labyrinthine approach, and the retrosigmoid approach, and the middle fossa approach. Every approach has its pros and cons. For example, the middle fossa approach is the best for hearing preservation, but is more good for smaller tumors. The translabyrinthine approach is very good for big tumors, but usually does not preserve the hearing. And retrosigmoid may preserve hearing. There is also the very important thing of preserving the facial nerve function. So sometimes you need approaches that more commonly preserve the facial nerve because it's very important for your facial expressions. So we're not only thinking about hearing, we are also thinking about the facial nerve. And sometimes, especially for large tumors, more than 3 centimeters, we may perform more of the facial nerve preserving surgeries. So this is a key facts or key ideas about vestibular schwannoma. Thank you all very much. If there are any mistakes or correction, please tell me. And that's it for now, I think. That's it.